So, in the last panel, we explored how early detection is one of the most powerful levers in healthcare. A timely diagnosis means the difference between recovery and avoidable death, and for systems, between prevention and the high cost of late stage care. Science is moving fast. The challenge now is making advances accessible, affordable, and actionable, especially in primary care and in underserved communities. Um, so, Colette, I'd like to start with you. Type 1 and type 2 diabetes are often detected far too late. How can we scale simple tools like risk tests or antibody screening so that detection becomes routine and not exceptional?
It's a really good question, which is actually how do you implement? And I think it's a really exciting time at the moment. We're seeing lots of new tools for detection, but actually there's a key question about why don't we use the ones we have already and actually make sure they really work. I think one reason it's a challenge is having conversations with people about risk. Human beings don't really understand risk at a very intuitive level, and it's quite hard to say to somebody you're at risk of a condition when sometimes there isn't the action they can take to make a difference to that risk. There's also risk and presentation. You can be at risk of a condition, but how it presents and how serious it is for you as an individual can be very different, which comes back to much more need for that sort of precision detection so that you can give more information to people. So that's the whole risk area. The next one is how do you engage both people with conditions or people before they've got conditions, and how do you get the health system to engage as well? It's quite hard for health systems, particularly if you know somebody's going to be detected with something, but you don't necessarily feel you've got the tools. And I'm sure we'll talk a bit more about that on sort of kidney care later on, where, kidney tests can be done, but healthcare professionals have voted with their feet because they don't feel they can then offer their patients something afterwards. Sure. So I think there's a range of different reasons why it gets stuck. But as you said, this is really going to impact primary care. And I was speaking to somebody from Genomics England the other day, and they were saying it takes painstaking work on healthcare pathways to get some of these new detection methods in there. So I think we've got to own up to the fact that this isn't easy. It does take real effort and people working together in quite different ways.
Absolutely. Yeah.
I think the implementation problem is the issue. We've heard this in another panel. And today, Björn from Saudi was talking about this, and we heard this in this panel, that the tools are on the table, but the implementation is far too low. And I think that could be a problem.
Absolutely. Yes, we'll dig into this a lot more. But Sandra, I was wondering if you could pick up from these points, because kidney disease is symptomless usually until it's advanced. So what would it take to make simple urine and blood tests standard practice in primary care? And what are some of these barriers to implementation?
I think they're simple tests. They're very cheap, as you indicated, and they're actually simple to deploy. How you then respond to what you find when you do the tests is, as Colette has said, is a bit more complicated. There's some big drivers for kidney disease. Diabetes is one of them, type 1 and type 2, and rare diseases is the other big driver. A whole pile of different rare kidney diseases is the other big factor. So we know that people both with diabetes and with one of these rare diseases in the family are at risk. So I would challenge that we therefore need to be exploring that risk with patients or people themselves. They may not be patients by the time they're first being seen. And I don't think that happens enough. And we hear that from people who are living with diabetes in the care of professionals for many years often. And no one mentions their kidneys. And quite often people say, why did no one tell me 20 years ago? I see the practice nurse every 6 months or every month, or depending on what stage I'm at, but nobody mentions my kidneys. And we know that practice nurses themselves, who are experts in diabetes care, are not thinking about kidneys. So we think that needs to change. Patients are asking for that to change. We need to use the power of their voice and their response, saying, if I had known, I may not have been able to stop myself reaching kidney failure, but I might have slowed it down significantly. And particularly now we have more treatments, so there is potential to really slow that down. It's not just dependent on the patient themselves. There's some exciting things on the table. So if you do know, you are alert, your healthcare team around you is alert to what you can do, with diabetes particularly being the driver, you can do something about it. So I think we need to be quite open about saying that's a failing if we're not doing that. That's not happening in primary care. We as two organisations have a responsibility to share that information with people at risk so that they themselves can be asking for that. Because some of the interventions are quite simple. You asked about what can we do to make things that are simple and available be more widely available. In the health check, which many of us will have at different points in our life or through our work employers, kidneys are not checked. So we had a whole team come in to do a test with all of our staff, kidney research all around the office, and none of us were given any indication about kidney health function because it's not included. And yet, from the samples that are taken in a GP surgery for general things, blood and urine tests, you can see indicators, but they're not the ones that are pulled out from the list that's on the GP's screen in front of them, and early enough, if at all. And I can perhaps cover some of that easy ways to do that later.
Yeah. But it sounds like low-hanging fruit in terms of changes that can happen. And Sevith, I wondered if you could pick up on this, because you've said early detection is only as good as the system around it, and that's sort of what we're talking about here. Can you talk about financing workforce models from your perspective, and sort of which of these are needed to ensure that screenings actually lead to timely care, especially when we think about this in low resource settings?
Yeah, 100%. Like we like to say, screening alone is not a solution unless it leads to actionable, affordable, and long-term care. So I can tell you, I'll get to the financing bit, but I can tell you with Indian Heart Association, I mean, we've ran campaigns related to hypertension and stroke awareness. And what we found was raising awareness was one small element, but we didn't see, but without parallel pathways like long-term follow-up, counseling, medications for statins and other antihypertensive medications, we didn't see long-term positive outcomes. So it's screening and early detection is the first step. And actually, paradoxically, it increases short-term costs, right? When you're getting a diagnostic test, it costs money. But the long-term cost savings are what's really beneficial: decreased morbidity, decreased hospitalization rates, etc. So with regards to the financing bit, another, besides Indian Heart Association, I'm also helping run a fintech startup in the healthcare space in India. And we're trying to see where predictive modeling can help. For example, diabetic retinopathy patients get early access to care before they get complications. So, almost predict, hey, they've been screened for diabetic retinopathy. We're predicting that if that's left untreated, that's going to lead to longer term costs. So how about we help them immediately or in the short term get access to finance and get affordable healthcare, and then see if we can help improve healthcare outcomes there. So screening and detection is absolutely only the first step.
Certainly. And Tomasz, I wondered if you wanted to pick up on this a little bit.
Yeah. I think actually Conrad destroyed our panel a little bit, saying that anything will be possible if the big pharma will be involved. And the bad thing about everything what we are talking about is not really big pharma are very much interested in that the implementation will be very, very widely accepted. And well, if not big pharma, then the public health. So that means that we have to change the concept from the healthcare as a cost to the healthcare as a benefit for the economy of the whole country. But that's another issue and another panel. But what I would like to say is that if we could make doctors or nurses in the community realize how easy it is and how much they can change it, that would be just wonderful. So I think our job together would be to search for that important click that makes them do it, because that's exactly what's in their hands. It's so easy to do, and they don't do it. And the question is why they don't do it.
Do we have, for the full panel, do we have any examples of success to address
We do. In diabetes, actually, there are a number of successes. And I think there's something about role of national or sort of the sort of system, and then what's the role of local, and trying to get that balance between the two. So here in the UK, we've got a national diabetes prevention programme. So that is commissioned on a national level. It's very highly evidence-based. So instead of having every local system inventing their own diabetes prevention programme and doing that early detection, you actually have it commissioned at a national level, but commission a wide variety of providers. So at a local level, they can select from them. I think that's a really good example. Again, if we look at the ELSA trial that Rachel was talking about earlier for type 1 diabetes, that's already reached 20,000 people here in the UK. That's because people have voted with their feet. It's quite a gutsy thing to put yourself forward to find out if your children or your family members have the sort of markers for type 1 diabetes. And in other parts of the world, people haven't stood forward, but there's a deep trust here for the NHS. So people have put themselves into that screening trial, and it means they're going to land into, if they're found to be at higher risk or to have those early antibodies, they'll land much more safely, much less risk of harm to life into type 1 diabetes when it does happen. So there's some really great examples. And I think hope's really important. I mean, it's really easy to say where it doesn't work, but there's an awful lot of stuff that does work, and it's how can we replicate those?
Definitely. Great points.
Can I give another example?
Yeah. Please do.
Good example.
Starting point, because you're starting from a point of opportunity to do something, which is fantastic to see that working. So in kidney, we looked at who had the worst statistics hospital-wise for people who arrived in an acute kidney state where their kidneys were failing with no previous kind of knowledge. It wasn't on anybody's expectation list. We call them people who've crash land into into a hospital setting with kidney failure. And the unfortunate group at this point, I'm sure, hope there's no one here from, and I'm not giving any information that's not known, was Heartlands in West Midlands. And so we funded a piece of work to say, well, why is that happening? Because most of those people will have some kind of primary care. So we invested in the labs in the hospital that were looking at the general bloods that were coming through and general tests that were coming through for the whole population of the GPs in the Heartland area. And they were asked to flag up in a slightly different way. So it was just adjusting, not doing any more tests, just adjusting how they represented the results back to the GP. So instead of saying the EGFR, which is the estimated filtration rate for kidneys, is today at 65, it was saying today it's at 65. Last year it was 75. The year before it was 85. So they were showing a graph to the GP rather than a statistic, moment in time statistic. So when the GP got the results back, they may have been sending blood tests for something completely different. Well, they mostly were. They would say, oh, actually, the graph here is quite, and they turn the idea is they turn the screen and show it to the patient and say, oh,
big difference.
There's something going on here. Let's have a bit of a better look at that. So that was, we had to pay the costs of the extra lab work, but it wasn't a huge amount. And all they were doing was using the data differently. And that was a few years ago. That will be easier now. In the lab, the team also looked to say, this is really high or a really steep decline, really low or a really steep decline. So simultaneously to sending that nicely presented GP result back to be shared with the patient, they also sent it to the nephrology team and said, you might want to talk to that GP in that practice because they're about to need you to advise on the health of this patient. So that's about dialogue, using data really well, very low additional costs. And Heartland's results completely changed. They went up to about the middle of the table across the UK of crash landing patients, which means better intervention, longer living well, and less, they're not arriving on the dialysis doorstep, which is extraordinarily expensive and a horrible, horrible treatment for people. So you want to avoid it, even if you're just gaining 5 more years, 2 more years, but ideally 20 more years, you want to avoid it. And just doing things differently, the dialogue is different. costs are quite low, and now we've got drugs that can slow down the disease. So not only will the patient know about it and perhaps need to look at some lifestyle activities to try and protect themselves, there are drugs that will help slow down kidney disease, which we didn't have a few years ago. So there's even more reason to dust down the kind of mechanisms we have and processes and be very patient focused on restoring people's opportunity to intervene early. And the GPs loved it because their job was, of course they could have looked back and said, what was it like last year and what was it like? But they're not going to in the setting because that's not why they're looking at that patient.
Just good visualization of data over time changed the whole process. Actually created the second step. That's what Sevith said, that if you are diagnosing something, you have to have something next step to follow because otherwise it's just unfair for the person who's being diagnosed. He's lost in lack of hope, actually, right?
Yeah, just to hit on that point, really making data easier, it has tremendous potential for really positive health outcomes. At Mass General Hospital at Harvard Medical School, I helped work on a dashboard which was used in the ER department for radiologists, and it's literally a simple speedometer system. When someone comes in with severe back pain that's life-threatening or something that's a little bit more chronic, the speedometer changes color. So if, using that example, if it's just a chronic low back pain condition, it's probably a little bit lower on the speedometer. But let's say a child comes in with head trauma, that's much more pressing. So this kind of dashboard workflow analytics system help radiologists. It's a very simple system, but it really helps
stratify the work. Which thing to do first, right?
100%. Yeah.
That's very practical. Yeah.
Really?
Actually, I actually had a chance to see a also very nicely visualized tool developed by some Norwegian startup that actually gives a visualization of different behavioral and analytic information of the patient, creates a digital twin, and you can change those things together with the patient, saying, okay, if you eat less pork, the chance of actually, this one was developed to evaluate the potential complications after colorectal surgery and what extent of rehabilitation should be and what specific type of rehabilitation should be administered to the patient. So if you eat less pork and you exercise more and you eat less salt, that means that the chances of not having the wound, the hissens, will be much lower after only 3 weeks of rehabilitation. So visualization of that was just perfect, nice colors, and it talks to the people, like to the GPs, but also to patients and to specialists as well. Nice colors and data.
Really interesting. I think that data visualization piece is really important, especially with the volume of data that is coming now from all of our tools. I'd like to shift gears a little bit and talk more about kind of the policy side of early detection. Health systems are under daily pressure. We've heard a lot in the conference so far to kind of manage the crises of today. How do you help leaders? How do leaders carve out political will, and importantly, sort of the financial headroom to invest in early detection? Often when we think about it as sort of a longer term investment.
Me? Yeah.
Anybody? Yeah.
Nice thing about the Swedish invention, I've also seen quite recently. So they developed a tool which is also personalized, AI-based one that collects information from the national database on the analytics and also self-reported, not perfect, but self-reported data on behavior concerning the physical activity and diet for the people with overweight and obesity. And what they did, they said they had an agreement with the private insurer that if the patient collects data for 1, 2, 3, 4, 5 years, the monthly payment for insurance in this private insurer for health insurance drops down. So it's incentive for the patient. And it works perfectly. And now the Swedish government in the area of Stockholm, they are talking about the possibility of using this as the governmental supported tool. And I think this is like direct approach to how to stimulate that kind of early detection, but also the early intervention in terms of practically free modification of healthcare prone behaviors. So that's the Swedish example.
Great, thank you.
And I guess from our example, I mean, a charity is basically a community of people that really look to the future and want to make a difference. So our role is, how do we make things practical? How do we make things actually happen? So first of all is sometimes doing the research or putting in the infrastructure around research that nobody else will do. If you look at around type 1 diabetes at the moment, we're funding the screening trial. We're also funding a data registry. So instead of there being lots of bits of data around the screening in different places, it will all be held in the same place. We also fund the networks of clinicians and clinical trials to make it as easy as possible to go to market. So that's what charities will often do, is fund the infrastructure, because nobody else will do that. If you go back to the sort of National Diabetes Prevention Programme around type 2, we helped go out, find the evidence, then worked with NHS England, Public Health England, and with people with diabetes critically to find out what was going to work, and then looked at how it could be scaled. And we still do work involving people with diabetes and looking to make sure that we're really tackling inequities, because that's another key role for charities, which is making sure these things are accessible to everyone. So why are some groups not availing themselves or not being offered some of these really important prevention measures or early detection, and making sure that the data's there, that people are facing into the data, and then action's taken. So sort of working across the policy sphere, from legislation right the way through to the sort of practical day-to-day of making it happen.
Makes a lot of sense.
Yeah, I think for really creating scalable screening and early detection programs that work, I think it needs to be a combination of the ministries, government, NGOs, startups that really need to come together. I can say from the private side, probably more guardrails and guidance would be needed, but I think a combination of public and private efforts absolutely would be beneficial. Having been brought up in the U.S. healthcare system, born and raised there, did my training there. Now I live predominantly in India. Can kind of see the contrasting approaches, but I also see a lot of similarities, interestingly, with the U.S. healthcare system and in the Indian healthcare system. Some things that the government are doing in India that's really beneficial is one of the largest healthcare insurance programs globally, called the ABPMJ system. And it's a phenomenal system that's really trying to help some of the lowest socioeconomic classes get healthcare. But sometimes some hospitals that deal with these patients, sometimes the government may be inadvertently slow on making payments to the hospitals. So where the public and private kind of relationship can come in is there's certain private startups that are going and helping these hospitals get paid on time until the government goes and pays them. So kind of alleviating that pain point there. So that's just one example, but I think there's so many examples across the whole healthcare spectrum where public, private can come together and make positive outcomes.
Interesting. That collaboration is really important. Yeah.
I think another angle perhaps is to look at how we can compel people to pay attention to you talked, your question said about the current health crisis. How easy is it to start looking ahead? Well, actually, those current health crisis statistics are getting worse and will get significantly worse unless we do something now. So I think we've at Kidney Research UK produced a paper talking about averting a public health crisis, and it was an economic-based paper, so I thought it might be helpful to share today. And that showed very compelling reasons, it was independently created for us, very compelling reasons that what might seem like expensive costs or slightly complicated, difficult things to tackle now, if we don't do it now, in a very short time, the scale will be beyond our ability to even start thinking about it. So kidney disease costs the UK alone £7 billion now. Well, in fact, not even now. It'll be more than that, because when this report was published, it was about 2 years ago. So that's probably more now. And the prediction was by 2033, So that's very soon. We're not talking decades away. That 7 billion would be 13.9 billion because of the scale of growth and expansion in the numbers of kidney patients. That's the cost. 10.9 million of that 2033 prediction is direct patient costs to the NHS for treatment. So that's not taking into account the overall scale of people not able to work, families living without working income. So it's even greater than that. And I think we need to really use those compelling arguments, which will be available in all of the large diseases and some of the small ones, to say there's an economic argument now to invest in not necessarily expensive indications to find out what you're dealing with, but to intercept and slow down the progress so that people don't reach these very expensive ongoing healthcare.
But maybe
we're just accepting is that's what happens. There's a solution. Maybe that in kidney disease, people think, well, there's a solution. You can have a transplant or you can have dialysis, but they're not solutions. They're just the way we can deal with it for now. We need to change that.
Maybe it's a thought that we had a venture capital representative during the previous panel, right?
Yeah.
So maybe, as you say, that the financial burden for the community, for the country, is so significant that maybe it's good. A lesson learned from Mayo Clinic. It's good to use the venture capital money to support the innovative solutions that will finally develop something that will be, well, bought by the government from the venture capital, which some may not like very much. But if we need a fast act, we need a fast money.
Yeah.
And the fast money is in the pocket of venture capital. And that's what Mayo Clinic does. All the innovations that they are pushing through is being supportive with venture capital, which means that those who are innovators need to think twice before they present it. So it has to be very much supported in the financial context.
Yeah.
And we have those data provided, and potentially we could also convince the governments to use this method, not using their own money, but use the investors, and then reuse the tools that are developed or the approaches that are developed in order to save the money that you mentioned are going to be spent anyway in the future. So it's
the whole
thing, yeah?
the whole idea behind social impact investing.
Yeah.
Right, yeah.
Do you have anything to add to that? Sevith?
Oh, yeah. Well, first of all, I think the United States healthcare system has many challenges, but one thing that it does really well is when it comes to tertiary care, a really challenging health outcomes. If someone has end-stage pancreatic cancer and they want a few more months to live, you can get a Whipple surgery in the U.S. And really, when things are really, really bad, the U.S. is an excellent place to get care. MD Anderson, you have world-class cancer centers, et cetera. And one thing the U.S. does very well is supporting, innovative solutions in healthcare. You mentioned Mayo. J&J has a tie-up with many different medical schools across America. So I think that's pretty well ingrained in, even students who go through medical school. Hey, I can go and build something and get it funded and do that. I think that's one thing that Europe could maybe learn from the United States healthcare system. I know that sounds crazy, but there's a lot more that U.S. can learn from European healthcare system, especially for cost-effective care and increasing access to care. But 100% agree, more venture capital money should be flowing into creating solutions that ultimately improve health outcomes.
But that means that the governments should guarantee that if the product is effective, it will be bought. Otherwise, the venture capital will say, no, we are not charity. We want to have the money back, which is, well, they can do it. But for us, the most important thing is the effectiveness of production. If they produce the thing that we want to use for decreasing the inequalities and all the other things, and the cost in future, maybe it's worth trying.
I think in that we need to not forget we're trying to bring this much further back in the journey. So it's not just about therapeutics, and that, I think there's a whole piece there about improved therapeutics and making them more available to everyone. But there's also the can we predict who might be at risk and intervene much earlier so they do not become, I quite often say, I don't want people who are in the care of Diabetes UK or in your sites, I don't want them to come into our territory at all. We should be not reaching that stage. And that isn't just about them having urine tests, because by then kidney functions are really beginning to decline. That's looking, and there's now the ability to see kidney decline through screening people's eyes by looking through, in ophthalmology, we can now detect kidney disease much earlier.
Yeah.
Possibly then to totally prevent that happening.
Yeah.
And that's where the investment needs to be, because that's where you really see the money. They won't because online very sorry, I thought I could hear some.
It's only us who hear you, but it was really wonderful talk.
Sorry, I'm not quite sure how that happened. So then you wouldn't be having that lifelong, very expensive treatment. You may need lifelong treatment, but much slower run into it, much cheaper.
Sure.
Because you're not reaching in our case, end-stage renal failure, which is enormously expensive.
Yeah.
And the other therapies that might see you through in a more gentle pathway to become a kidney patient, but in later life, is much cheaper. So I think all of those things need to be costed in, and for me, it's all about people, but money counts in lots of settings.
Of course.
And we have to utilize and exploit the monetary cost to get change to happen at the beginning.
Can I just one word? I just wanted to emphasize that I completely agree with you that the problem is the people, that actually, as I said, the primary care physicians, nurses, etc., they could have done much more, but out of unknown reasons, they just don't do it. Most likely it's because there's so much work they have to do and they have to remember about many things. But what I wanted to say is that maybe there is a method to change it with this venture capital context. Why? I mean, if we provided them, and this comes together with future and AI in health, if we provided them with tools, such as electronic thing attached to their primary care informative system of whatever, that is collecting data and giving them some kind of information, well visualized, as we mentioned, which is important, and stimulates them to do additional tests like eye evaluation or urine test, and that comes together in a package and is being sold, is being developed by some kind of scientists, and it's being financed by venture, it's being sold to the government, and then used as an attractive tool, because every nurse and every healthcare professional has a telephone and smartphone and nice apps. So they do it, they can do it. And if it's sold nicely and the tool is good, they will be maybe more eager to do that. Not only for money for each of the diagnosed person, which is also possible. And then we go more American way, right? Than solidarity European way. But that's also an option. And then the venture capital can say, all right, this thing can be financed by us because the government will buy this from us. And finally, the effect is the one that we are talking about today.
Yeah, I know we're running short on time, but there are some solutions coming out now. I think it's really exciting. There's IDX DR, which is an AI-powered diabetic retinopathy app. Literally, you can make diagnoses with, but then that predated the AI hype cycle. And if you can get governments involved too, that's something I don't think you see a lot of in the US yet. I would love to see if governments can buy these kind of solutions. I think it would be really...
That would be wonderful. We don't trust governments that they will make good use of it. But let's pray that they will. If venture capital pushes them, then there is a chance. And at the end, the patients will benefit, which is the most important panel.
Absolutely. We've unfortunately run short on time for questions, but I think if we can just quickly wrap up with a final insight from our panelists. Oh,
there is a pressure.
A quick one. Okay. Oh, sorry, a mic is coming. Just a moment. Yep.
Colette Colette talked about equity and how important that is, and community-centered approaches are really important, and we see a disinvestment in terms of inequalities budget, and when actually the chasm of inequalities is getting larger, fueled by class inequalities and race inequalities, and so we have a perfect storm in many of our metropolitan cities. So it's really important to understand how important it is to engage those trusted leaders, trusted voices, trusted places in our community, both in the industrial north of England where I was brought up, but also importantly to engage mosques and synagogues and mandirs in London as well. So my kind of key point is about, so I have to do a lot of work to build trust and confidence in our communities in a time when we have real fiscal constraints on that. So we have the 10-year plan, which is focusing on sickness to prevention, analog to digital. But the key point is, in terms of sustainability, we've got to invest in communities, because you can have nice ideas fueled by venture capitalists and pharma, etc., and that sounds great, but it's the value beyond the pill. The value beyond the pill is actually getting societal value, moving from transactional to relational, because the farmer not going to get the drugs taken and adherence problems. And also, I'm still trying to clear up the mess that certain vaccine manufacturers did in Nigeria in order to improve the vaccine confidence and behavioral change, because people don't forget that easily. We know there was a German manufacturer in the 60s that led to certain things. That's why we have the word pharmacovigilance. So it doesn't matter whether it's German or not. Every single nationality and pharma company is global. But what I'm trying to say is that communities have a bit of a disdain to pharma, and it's important to kind of contextualize it. So we're doing that actively, allyship, at community level. But I'm a little bit worried about the venture capitalists, particularly in an intensely public system like the UK, where the NHS, as Colette said, is so trusted. I worry about the kind of financial portfolio of that VC, and whether that aligns with the moralities of Abrahamic communities, etc., and all that kind of stuff. These things have to be looked at. It's a great idea on paper, I agree, but maybe we can actually soften that collaboration with pharma. Obviously, they have ABPI Clause 2 and things like that prevents them from working directly with communities. But there have been projects like the unseen, unheard work that Gilead did. I'm no declaration of interest, I don't work with Gilead. But what I just wanted to say is that things like that, where I'm trying, and many of my colleagues are trying to reach certain communities, like say the Bangladeshi community in London, in Birmingham, etc. With decreasing budget, there could be potential collaboration between, say, ICBs, the payers, who act as middlemen between the pharma companies and the communities. There has to be a better way around, because at the moment we're putting a lot of expectation and demands on the community that have different daily variations of trust, distrust. And as we know, we are a heartbeat away from Warsaw, Praha, Dhaka, Islamabad, and Lisbon. So what I'm trying to say is that our communities are diasporic, as well as being under a lot of industrial strain for the last 20 years. In order to build that trust and confidence, we've got to have a new pathway for collaboration. And I don't believe in this thing, we can't believe in pharma, we can't do this, can't do that. No, there's a place for ethical collaboration, but it's about ensuring that you have the community in mind. Colette, we partner with Diabetes UK, I will declare that. There was no funding from Diabetes UK, but what you gave us was social capital with Aoife Slattery. So back of the cigarette packet idea of connecting with the Bangladeshi community, 350k in London, created the London Bangladeshi Health Partnership. And Diabetes UK, in order to actually improve vaccine, we realized that you have to engage on diabetes, where the people are more concerned about, and still talk about vaccinations. But by working with yourselves, we will be able to create a platform with trusts and primary care and community groups to ensure that real trust is gained with that community, and it goes and it's accelerating now beyond where it started. But that's an example of a startup that started from system people like me who have some understanding of certain communities. But we need more innovation. And Tomasz, I'd love to speak to you about how we can actually fund that community innovation. Because what we do in London, this is an international city where everyone is loved and wanted, we can do in New York. So I need to be comparing vaccination rates in London with Brooklyn. I need to be comparing, for Bangladeshis, I need to be comparing vaccination rates of Somalis, not with Mogadishu, but with Stockholm. This is the new type of reality that we live in, but many of us are in a state of denial. But we will save you money, and we'll improve cohesion, and we'll make for a better world to live in, a bit more happier place as well.
You guys have to invite this gentleman to the panel next time. Come on.
Don't worry. We
We
connected
lost
already.
an important voice.
We
Yeah.
connected already. Don't worry. Yeah, thank you very much.
Thank you. Actually,
yeah.
a comment. Well, it's
I know.
difficult to react.
And I'm not sure how brief it was, but it was
Yes, we
incredibly
agree, we
important.
agree.
It was incredibly important. So thank you very much. I only say that because we're now headed into lunch. So thank you everyone for your attention. We're going to dig into that issue much more in a panel this afternoon. So thank you very much. We'll reconvene here, I think in an hour's time, to open our Health for All track. Don't miss it. Lots of good sessions. Thank you.